Hello, everybody, and welcome to our free course through the COVID-19 magnifying glass, an examination of racial and SES disparities in the U.S. My name is Dr. Danielle Ompad, and I'm an associate professor of epidemiology at the New York University School of Global Public Health, and I'm here with my colleague.
Hi, I'm Dr. Melody Goodman. I'm the Associate Dean for Research and an Associate Professor of Biostatistics at the School of Global Public Health.
So we want to thank you for joining us today. There's quite a few people here. So to kind of organize ourselves, we're going to ask you to put any questions in the Q&A, and please check to make sure that your question hasn't been answered before you add one, only because there are hundreds of people on the call, so it'll become a little bit challenging to manage if everybody puts the same question in the Q&A. So we're going to get started, and today is going to be a tag team lecture, but what we thought we would do is kind of introduce you to our school, but also introduce you to this course. So the course schedule today, you're going to have lecture with myself and Dr. Goodman, and we'll be giving you a COVID-19 overview. So the point of today's lecture is to make sure that we're all on the same page when it comes to the biology, the clinical manifestations, the epidemiology, and the measurement of COVID-19. So then that will help you engage with the rest of the week, where we will have, tomorrow we'll have Dr. Keon Gilbert, who is an Associate Professor of Behavioral Science and Health Education at St. Louis University. On Wednesday, we'll have Dr. Kamara Jones, who's the Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study, Harvard University. She is also a Senior Fellow at the Morehouse School of Medicine. And then on Thursday, we'll have Dr. Na'aoyo Kwate, who's an associate professor in the Department of Africana Studies at Rutgers. And then we'll wrap up on Friday with Dr. Daryl Hudson. He's an associate professor at Washington University in St. Louis. So we're really honored to have such a stellar lineup of scholars who will help us unpack the COVID health disparities that you're probably hearing about on the news. Some of you may be directly affected by this, and hopefully we will be able to shed some light on this for you and help you think through what we could do to alleviate or eliminate these disparities. Is there anything else I should add, Dr. Goodman? Okay. So the other thing is my one shameless plug. If you are interested in a graduate degree in public health, our fall 2020 applications are still open at the New York University School of Global Public Health, and we do not require a GRE. We have some upcoming online information sessions on July 31st, August 7th, and August 14th. So if you are interested, you can go to this website, and we'll try to get it into the chat for you before the end of the class today, if you want to speak with an admissions officer. So I'm sure Dr. Goodman agrees that it has become very clear that public health is critical to the functioning of the global world, but also the United States. If you had never heard of an epidemiologist before January, you understand that epidemiologists and biostatisticians are currently the rock stars of public health, although there are a lot of other rock stars. And this is our opportunity to help the world cope with a devastating pandemic. We have trained our whole lives for this, and we can offer an opportunity for you to train to be a part of this solution. Okay, that's enough of my shameless plug. So let's get started. So what I'm going to do is provide an overview of COVID-19. But in order to do this, I want to briefly introduce you to the concept of infectious disease epidemiology. So I'm going to go over some key concepts, particularly ones you may have heard on the news. I'll talk a little bit about methods and prevention approaches, and then we'll dig into SARS-CoV-2 and COVID-19. And we'll talk about the characteristics of the virus, the clinical presentation of the disease, and then I'm going to show you some data. And when I'm done, I will turn it over to Dr. Goodman, who will talk about measurement. And then when that's over, we will have 30 minutes for Q&A, so you can post your questions in the Q&A. Okay, so let me give you an introduction to infectious disease epidemiology. This is what I was trained in. I am an infectious disease epi nerd, and these methods and this career has made me incredibly happy, and I have the ability to contribute to society in some small way, I hope. So infectious disease epidemiology is the population-based study of infectious diseases. That includes things like viruses, so like SARS-CoV-2, bacteria, fungi, parasites, even prions. So if you think about Creutzfeldt-Jakob disease, or also called mad cow disease, that's actually caused by a prion. So infectious disease epidemiologists can study all of that. We're also interested in research that is related to the primary, secondary, and tertiary prevention of disease. So I'm going to come back to this in a few moments, and I'll explain to you what I mean by primary, secondary, and tertiary prevention. This is a gorgeous picture of methicillin-resistant Staph aureus, also called MRSA. So we get to study really interesting diseases. So how do we differentiate infectious disease epi from clinical infectious diseases or microbiology? One way to think about this is the type of research questions that we may ask. So if you're in clinical infectious disease researcher, you might ask, what are the signs and symptoms of the disease, or how do I treat the disease? If you're a microbiologist, you might be interested in what are the characteristics of the organism. Is it a virus? Is it a bacteria? Is it gram-negative? Is it gram-positive? How does the organism behave? And you might be interested in what is the protective immune response. So what does that mean? That means how does the body react to the organism? If you're an infectious disease epidemiologist, what we're trying to do is figure out what is the reservoir? Where did this disease come from? How is it spread? And what are the risk factors for infection? So I thought I would go over some key concepts in infectious disease epidemiology. There's a lot of terms that are being thrown around in the reporting. And so I thought I would demystify and clarify some of these terms for you. First of all, an epidemic is the occurrence in a community or a region of cases of an illness, a specific health-related behavior, or other health-related events clearly in excess of normal expectancy. So an epidemic obviously could be something like COVID-19. You could also say that there is an overdose epidemic, particularly related to opioid overdoses, right? So the number of overdoses that we've seen in the past few years exceeds what we would normally expect. So it doesn't have to be an infectious disease for it to be an epidemic. The community or the region and the period in which the cases occur should be specified precisely. So you have to be very specific about where you're talking about and when you're talking about. And then the number of cases indicating the presence of an epidemic varies according to whatever the disease-causing agent is, the size and the type of population exposed, previous experience of lack of exposure to the disease, and time and place of the occurrence. So for example, 5 cases of influenza, like the flu, in October in New York City would not be an epidemic, right? Because that is not in excess of normal expectancy. However, 1 case of Ebola in New York City at any time would be an epidemic because we do not expect to have Ebola cases. So that's what I mean by saying that the number of cases that decide whether or not something is an epidemic is going to vary. It's going to vary in terms of the situation as well as the agent. So an outbreak is an epidemic limited to a localized increase of disease, like in a village or a town or a closed institution. So for example, a few years ago, there was a HIV epidemic in Scott County, Indiana. And that was a very geographically limited outbreak of HIV during a particular period of time. Endemic is the constant occurrence of a disease, disorder, or infectious agent in a geographic area or population group. So it's kind of like the baseline, the baseline number of cases of a particular disease that you would expect. So it could be chronic high prevalence of a disease in such an area or group, right? A pandemic is an epidemic occurring over a very wide area that crosses international boundaries and usually affects a large number of people. Okay, so we're going to come back to the idea of pandemic in a minute. The other thing you might hear about is incubation period. So the COVID incubation period is 2 to 14 days, and the incubation period is the period of time between infection and signs or symptoms of the infection. So it's from the moment you become infected with the virus or the bacteria or the protozoa to the moment that you display any signs or symptoms. And so that incubation period is really important because that's a period for some diseases where you actually may be able to transmit the disease without even knowing that you have it. Now, there are 3 main types of COVID infections that you probably hear about in the news. There are symptomatic cases. So those are people who have COVID and they have COVID symptoms. Asymptomatic people, so a person who has COVID but never develops the COVID symptoms at all. So they'd only know that they have been infected because they test positive. Pre-symptomatic people are people who have COVID and do not have symptoms at the moment, but eventually develop symptoms, right? So you can talk about people being symptomatic, they have COVID and they have symptoms. Asymptomatic, they have COVID, but they never get symptoms. And pre-symptomatic, it's basically somebody who has COVID, but has yet to develop symptoms, but they eventually do. Now, there's been a lot of talk about immunity, and I know some of you might have had a biology class a while ago, and so I thought it might be helpful to talk a little bit about the immune system and immunity. So immunity is the capacity of a person when exposed to an infectious agent to remain free of infection or of clinical illness, right? So it's not just that you fight off the virus, you could actually get infected but just don't have any symptoms, right? Or clinical illness. Herd immunity is the immunity of a group or community, and the resistance of a group to invasion and spread of an agent based on the resistance to the infection of a high proportion of individual members of the group. So the way this kind of works is that if enough people are immune to the disease, then the likelihood that somebody is susceptible is going to run into somebody who has the disease is lower because so many people are already immune. And the resistance is a product of the number of people who are susceptible and the probability that those who are susceptible are going to come in contact with an infected person. Now, in terms of your immune system, there are actually organs of the immune system. So like your tonsils and your adenoids, your lymph nodes, your lymphatic vessels, your thymus, your spleen. Your skin is actually part of your immune system. It's one of the first defenses against invasion by infectious agent. But you also have what's called cellular immunity. Now, there are lots of parts of the immune system, and we could, have a whole semester-long course about the immunology of the human body, but I'm going to focus on 2 things that you probably hear about a lot in the news, and those are IgM and IgG antibodies. So antibodies are basically chemicals that your cells make to fight off an infectious agent, right? And sometimes not even just an infectious agent, but a foreign agent, right? So IgM is your largest antibody, so it's big, and it's the first antibody to appear in response to the initial exposure to an antigen. So an antigen is basically like a protein or something foreign that your body reacts to. When your body is creating antibodies, it doesn't typically create antibodies to the whole virus or the whole bacteria, but rather typically they react to things on the surface of the infectious agent. IgG makes up about 75% of your serum antibodies. They're created by B cells, and they're found in your blood and your extracellular fluid, and allows your body to control infection. It binds to many types of pathogens like viruses, bacteria, and fungi. So the way to think about this, I think about this in terms of boxing, right? So let's say that I'm Mike Tyson, because I just saw him on HBO this weekend. So if I'm fighting a new opponent, my first round, I'm going to be trying everything that I can, and I'm not going to be that specific because I'm trying to figure out what this person's weaknesses are. So IgM is kind of like a boxer in the first round in that it's a large antibody. It's kind of taking the approach of a more general response. It's not as highly specific as IgG. IgG is like Mike Tyson in the fourth round. I figured you out. I know what your weaknesses are. I know that you're not good on your left side. So I come with a left cross or uppercut from the left side because I know that that's what's going to knock you down. And so IgG is very much like that. It's a highly specified antibody that is going for particular parts of the virus or the bacteria, right? So IgM is a little general. IgG is way more precise. And so we often are waiting for the IgG response to mount so that we'll have better immune response to that agent. Hopefully that makes sense. So when we think of agents, and by agents, you know, I'm referring to viruses and bacteria and things like that, we think about infectivity, pathogenicity, and virulence. So infectivity is the ability of an agent to enter, survive, and multiply in the host. It's a function of both the agent and the environment required by the agent, right? Quantitatively, it's like the secondary attack rate, which is the attack rate, it's the people who get the disease from the first round of people who got the disease. That's how you can think about the secondary attack rate. Pathogenicity is the degree to which the agent is able to multiply or cause disease in the host, right? So infectivity is just whether or not the agent can infect you. And pathogenicity is whether or not it can actually cause disease and multiply. And virulence is the degree of pathogenicity of an agent and the extent of damage to the host by the agent. Meaning, so virulence is how sick is it going to make it? How dangerous is it to you? The other thing you probably hear a lot about on TV is different types of cases. So for COVID, generally what I see, I mostly watch CNN and ABC. I hear them talking about confirmed cases, probable cases, laboratory confirmed cases, and sometimes, but rarely, clinically compatible cases. So a confirmed case is a case that is classified as confirmed for reporting purposes. And a probable case is one that is classified as probable for reporting purposes. So how do you determine whether or not something is a case? Well, you have a case definition. And case definitions will often change over time as we learn more about the disease. So for example, in the beginning, a case definition may simply be a constellation of symptoms until we identify the causative agent. Once we identify the causative agent, we might add that somebody has to test positive for the agent for them to be a confirmed case. A probable case is usually somebody who has the disease, but we may not have the lab results back on them, or there may be a possibility that it's another diagnosis. A lab confirmed case is one that's confirmed by one or more of the laboratory methods listed in the case definition, because case definitions are very specific definitions. They're typically developed by organizations like the Centers for Disease Control or the WHO, the World Health Organization, and so they're very precise. And it can even be precise to the type of test that is acceptable or not. So it could be that it's based on the RNA test or an antibody test or maybe a sputum test. It's going to depend on the agent that we're talking about. And although other laboratory methods may be used in a clinical diagnosis, only that methods that are listed in the laboratory criteria for diagnosis are acceptable for laboratory confirmation in terms of reporting purposes. Now, a clinically compatible case is basically somebody who has a clinical syndrome that's generally compatible with the disease, but no specific clinical criteria need to be met unless they are noted in the case classification. So this basically means that the case is consistent in terms of signs and symptoms with what the case definition is. Okay, the other thing you guys might hear about is the R naught. So that's the basic reproductive rate. And this is one of the things we talk about when we're talking about herd immunity and what it takes to get to herd immunity. So the R naught is the number of infections produced on average by an infected individual in the early stages of the epidemic when virtually all contacts are susceptible. So an outbreak is expected to continue if the R naught has a value greater than 1 and to end if the R naught is less than 1. So what do these numbers look like? Well, the R naught for measles, which is highly infectious, has been estimated to be 3.7 to 203.3. That's from a systematic review of R naught for measles. For COVID, it has ranged, in Italy, the estimates range from 2.43 to 3.10. And in Wuhan, China, it ranged from 0.3 to 3. So what is another way of thinking about R naught? R naught is basically the average number of cases an infectious person can infect, right? So the larger the number, the higher the vaccination coverage needs to be for us to meet herd immunity. So that's why R naught is so important. The other thing I thought I would introduce you all to, because again, not everybody in this class is an epidemiologist or even somebody who has been trained in public health, is what is called the classic epidemiologic triad. So when we think about the occurrence of disease, we think about it in terms of the agent or the disease-causing agent, the host, meaning the organism generally, and for me in particular, humans, what are the host characteristics, and then what's going on in the environment. So examples of agent factors include the ability of the agent to spread, for it to induce infection, and for it to produce disease. For environmental factors, we can think about physical mechanisms like food and air and water. We can think about biologic mechanisms such as vectors, meaning vectors are basically animals or organisms that may spread disease. You can think about the climate, you can think about the setting generally. And what we're going to talk about in this class in the 4 days, Tuesday through Friday, are social determinants of health. So these are environmental factors of the social environment, including policies and structures that shape our health and our health behavior. And then, oops, 2 seconds. Host factors include your behavior, you know, so whether or not you're, for COVID, whether or not you're wearing a mask and social distancing, whether or not you've traveled, potentially occupation, and infectivity related factors, maybe your age, to a certain extent for some diseases, your genetics, and your immune status. What's also important to know before we talk about COVID are some general routes of transmission. So routes of transmission are basically how can you get diseases, right? So some diseases are transmitted with direct contact with the tissues or fluids of an infected individual. So this could be fecal-oral transmission, meaning, so fecal-oral transmission is like, I go to the bathroom, I don't wash my hands, and I'm a food service worker and I prepare your food with my hands that have not been washed. And if I have hepatitis A, I could potentially pass that on to you, right? So fecal oral, meaning basically poop, right? Poop to mouth. The other direct contact include things like sexual behaviors. So having sex without a condom or not being on PrEP can transmit HIV. Syphilis is also sexually transmitted. So sometimes you have to wear a condom to prevent transmission of particular diseases, but for HIV, we know that there is something called pre-exposure prophylaxis, that you can take a pill every day to prevent your you from acquiring HIV. Indirect contact includes things like fomites and airborne or aerosol transmission. So fomites is one of my favorite public health words. It's one of my favorite epidemiology words, and students who have had me know that I love to talk about fomite. So what is a fomite? A fomite is, let's say I cough into my hand and then I use a public computer. Whatever I coughed up is now on that public computer, and that is a fomite, right? So it's basically leaving things on surfaces. That's why it's so important to wash your hands or to sanitize your hands and to be careful about what you touch. So if I cough and I open the door and touch the doorknob with my bare hand and I've coughed into my bare hand, I've potentially contaminated the doorknob. Now, this is not to make you anxious, right? I mean, this happens on a daily basis for all sorts of things. But we should definitely be careful nowadays about maintaining clean hands and not touching surfaces that we don't need to. Airborne or aerosol transmission is basically droplet transmission through the air. So if I cough in the immediate area, there might be some droplets that could get on you. And farther away, there'll be like very fine aerosol particles. It's kind of like a can of hairspray. When you spray that, that's like an aerosol. So that can come out of your mouth or your nose as well. There's also food and water transmission, like salmonella, listeria, E. coli 0157, or cholera. They can all be transmitted through food or water. There are also vectors. So there are insect vectors like mosquitoes or flies that transmit malaria, yellow fever, or plague. Fleas can transmit plague. And you know, there was a plague, there was an animal that was identified as having plague a few weeks ago in the US. And there's also some plague cases, I think, in Mongolia right now. Invertebrate animals like snails are vectors for things like schistosomiasis, and vertebrate animals can be vectors for things like rabies or Q fever. And there's also the possibility of perinatal transmission, which is basically mother-to-child transmission, things like HIV, syphilis, herpes simplex 2 virus. It's unclear right now if COVID is perinatally transmitted. There seems to have been at least one case in Italy, but the jury is still out. In terms of reservoirs, humans can be reservoirs, right? So reservoirs are basically places where the agent hangs out and where it can be spread from. So like I said, HIV, syphilis, herpes, humans are the reservoir. Animals are the reservoir for brucellosis, anthrax, viral encephalopathies, rabies, plague, non-typhoidal salmonella, Lyme disease, you know, that's transmitted by the deer tick, and COVID also has some animal reservoirs. Water can transmit cholera, giardia, schisto, cryptosporidosis, Naegleria fowleri. So Naegleria fowleri, remember, is that they call it the brain-eating amoeba that you can get from swimming in certain freshwater sources. And you can also, soil can also be a reservoir for things like tetanus, botulism, and histoplasmosis. So I will say, typically what happens to an infectious disease epidemiology student is whenever you're taking ID-Epi, you develop an acute case of, oh my God, what do I have today? Because we spend a lot of time talking about different diseases. But you know, most of us run through life being rarely exposed to these or recovering when we're exposed. So this is not to make you anxious or anything like that, but just to give you a sense of what we do. The next thing I want to talk about is the Epi Curve. So if you've watched the news anytime since about the end of January, you've seen an Epi Curve. An Epi Curve is a visual display of the onset of illness among cases that is associated with an outbreak. So the x-axis or the horizontal axis is the date or time of the illness onset among the cases, and the y-axis is the number of cases. And each axis is divided into equally spaced intervals, although the intervals for the two axes may differ. So what can it tell you? It can tell you the mode of transmission, the timing of exposure, and the course of exposure, right? So this is actually the global epidemic curve for COVID, and we'll look at that a little bit more closely in a minute. So an Epi Curve, if you graph the onset of cases over time, you can actually begin to understand the epidemiology of the disease. So this is an Epi Curve for point source epidemic. This came from a CDC training module. It is an epidemic of cryptosporidosis cases associated with a child care center. So people with a point source epidemic, people are exposed over a brief time to the same source, such as a single meal or an event. When I was training in epidemiology, the first outbreak investigation you do as a tabletop exercise is an outbreak of E. coli or salmonella at a church picnic. And you basically plot the epidemic curve and then keep track of what everybody ate to figure out what was the cause of the outbreak. The number of cases rises rapidly with a point source epidemic to a peak, and then it falls gradually. And the majority of cases occur within one incubation period of the disease. A continuous common source outbreak is where people are exposed to the same source, but the exposure is prolonged over a period of days, weeks, or longer. And the Epi Curve rises gradually, and it might plateau, and then eventually it comes down. So an example might be this salmonellosis outbreak for people who were exposed to contaminated salami. So often a continuous common source outbreak might be a foodborne outbreak, often at the level of the manufacturing. So like when you see those outbreaks of salmonella or E. coli related to alfalfa sprouts, or I've also seen it for ground beef, that may very well be a continuous common source outbreak. And then a propagated outbreak is where there's no common source because the outbreak spreads from person to person. And the graph will assume the classic Epi Curve shape of progressively taller peaks, each one being one incubation and period apart. And this example, our measles case by date of onset, I think this was in Wisconsin, but I could be wrong. And so plotting the cases by date of onset helps us understand potentially the incubation period of the disease that's occurring, as well as we can use it to actually help predict what type of outbreak it is, and then also the course of the outbreak. So a lot of the models that you saw on the news use the Epi Curve to kind of predict where we were going to be. It's a little challenging to do the modeling, and maybe we can get Dr. Goodman to talk a little bit about that, because things change over time and the way people behave change over time. Okay, I told you that I was going to talk about primary, secondary, and tertiary prevention. So epidemiologists and people in public health are not just interested in measuring the disease, we want to prevent disease. So we don't do science just for science sake, we do science in the service of the public's health. So primary prevention aims to prevent disease from developing in someone who does not already have the disease. So childhood vaccines are the classic example of primary prevention. We vaccinate people for diseases before they get them so we can prevent them from getting them. Secondary prevention is the identification of people with risk factors for disease, or they have early stages of the disease, and we identify those people through screening. And then we basically provide an opportunity to intervene early, which can reduce morbidity, meaning sickness, disability, or mortality, meaning death. So a classic example of this is HIV counseling and testing. So for HIV counseling and testing, we test people. In the process of doing the counseling, we talk about why people may be at risk for HIV, how they can reduce their risk. And if it turns out that they're negative, then we try to counsel them about how they can stay negative. And if we identify somebody who is HIV positive in 2020, we get them on medication as soon as possible, because if you get on medication and the medication works for you and you take your medication as directed, you can have an undetectable viral load. And undetectable means untransmittable, which means that you're not going to transmit HIV to somebody else. In addition, if you're HIV positive, we'll talk about other ways in which you can help yourself stay healthy and to prevent transmission to others. And then tertiary prevention, it focuses on people who already have the disease. It's concerned with improving the symptoms, functioning, and quality of life for the patient. A classic example is directly observed therapy for tuberculosis. So often, if people test positive for tuberculosis and they actually have the infection, departments of health will go to that person's job or home every day to make sure that they take their medication, because that will improve their symptoms, functioning, and quality of life, and also reduce the likelihood that they spread and or develop drug-resistant tuberculosis. Okay, I think this is the last intro to ID-Epi. We call it ID-Epi, if you're in the know, if you're a cool person. So when we're thinking about an infectious disease epidemic, we want to characterize that epidemic or that pandemic. So when we characterize the epidemic, we think about the agent and the disease, the type of agent, what the host immune response is or the person's immune response is, what are the signs and symptoms of the disease, and then we think about who gets the disease in terms of person, place, and time. Who is at increased risk for getting the infection, getting the disease, getting severe disease, or dying from the disease. And so in COVID, we think about who's likely to test positive, who's likely to be symptomatic, who's more likely to be hospitalized, and who's more likely to die. Then we think about place. So we think about what are the geographic, ecological, and socio-political characteristics of the affected communities. You know, we used to only think about place as geography and the physical environment, but now we also think about the socio and political characteristics, because that can play a big role in the development of disease. And then we also think about time. We think about time in terms of calendar time or season of the year. When COVID first came on the scene, people were hoping that we'd see a reprieve during the summer. That sometimes happens with respiratory infections, but that's not what we have seen. We can think about time from exposure to symptoms, right, which would be the incubation period, time from symptoms to recovery, or time from symptoms to death, right? And the latter is really important because we need to kind of know what time frame we're working in terms of treating people and trying to prevent that mortality. Okay, so now I'm going to switch gears and talk about SARS-CoV-2 or COVID-19. I see that there are a lot of questions in the Q&A, but it's a little challenging for me to toggle between the Q&A and the slides. So I'm going to go through the slides and then we can go through some of those questions afterwards. Okay, so Dr. Goodman is going to have a poll for you here shortly, hopefully. But I wanted to share with you the early SARS-CoV timeline. And we've already talked about the definition of a pandemic. So I want you to keep that on your mind as we look at this. So the first case was identified or reported on December 31st, 2019, and it was a media statement by the Wuhan Municipal Health Commission from their website, where they reported cases of viral pneumonia in Wuhan, China. And by 9 January, the WHO, the World Health Organization, announced a mysterious coronavirus-related pneumonia in Wuhan. So the first confirmed case was January 2nd in China. Then the next confirmed case was January 13th in Thailand. 3 days later, there was a case in Japan. 4 days after that, we had reported confirmed cases in South Korea and the US. 21 January, we had a case in Taiwan. 22 January, Hong Kong, Macau, and so on and so forth through the 31st. So when did COVID become a pandemic? And hopefully Dr. Goodman can help us with the poll.
The poll is activated. To participate in the poll, I put the information in the chat box.
Great. So I'm going to click on that. So if everybody could copy that or text.
I'm going to share my screen.
Awesome.
I'm going to take you down.
Sounds good. Okay, so how many responses? How cool is this, y'all? Okay. It's all good. If you, oh, go ahead.
I was saying, I see some people responding in the chat.
I know they were having problems with the poll. It's okay. We still see it moving a little bit.
Yeah.
Okay. I'll give you guys a couple more minutes. By the way, as an epidemiologist, watching the numbers go up and down is so exciting to me. Are you nerding out, Dr. Goodman?
I am. I think, oh, as soon as I was gonna say, I think we slowed down. There's more people coming in.
Okay, right on. Okay, so there's still some variation. It's okay if you can't access the poll, but I can see, you know, people responding in the chat. So it's all good. On average, it would seem, and there's still a little bit of voting happening, at least in the poll everywhere, the largest proportion think that it became a pandemic in late January, followed by March, early January, and then February. Okay, thank you guys for responding. So now I got to share my screen again.
Sorry about that.
No, it's okay. It was awesome. So if you remember the definition of a pandemic, right, it was basically multiple cases across multiple international borders. So arguably you could say early to mid-January because 3 countries are involved. It's probably better, it's probably more accurate to say late January. However, what's interesting is when did WHO declare COVID a pandemic? Now, some of you might have actually been giving this response because they did not declare it a pandemic until the 11th of March. So there were a larger proportion of people who said March, and I'm guessing that some of you might have been going by when the WHO made their announcement rather than the epidemiologic definition of what is a pandemic. But I think you could arguably say that by the end of January, late January, we were in the beginning of a pandemic. Okay, the other thing I'd like to point out to people is that everything we know about COVID, we have learned since the 31st of December, 2019. And so if you walk away from nothing from today's lecture, you will understand that the reason why the information on TV is changing is because we're learning more. It's not because we don't know what we're doing, although, you know, arguably we don't always know what we're doing, but we're trying our best. But it's because we're slowly learning about this. This is a new virus. We've had other coronaviruses circulate before, like SARS-CoV-1 and MERS, the Middle Eastern respiratory syndrome. But SARS-CoV-2 is a new virus. So everything that we've learned has happened since the 31st of December. Now, I did this analysis at the beginning of July. And by the beginning of July, if you did a literature review on PubMed, which is like the database where most biomedical research is published, if you just use the terms COVID and SARS-CoV-2, you found 29,227 articles. And so that was through the beginning of July, which is why the July bar is so low. But imagine trying to keep up with that literature, right? So there is a lot being published and a lot is being learned, and we're still learning, and information is going to continue to change. So you should just be prepared for the idea that we don't know everything, and something that we know today is going to be different maybe a month from now. So let's talk a little bit about the agent, which is SARS-CoV-2, which stands for SARS coronavirus 2. Coronaviruses are named for the crown-like spikes on their surface. So this is an image, an artist's image of SARS-CoV-2. And so those little blue and green spikes are those little crown-like spikes on the surface. There are 4 main subgroups of coronaviruses, and SARS-CoV-2 is a beta coronavirus. I'm going to get a little bit biologically nerdy for a moment. It's an enveloped, positive sense, single-stranded RNA virus. So when you hear on CNN or ABC or even Fox about RNA tests, they're testing for the genetic information, the presence of the genetic information of the virus. So enveloped means it has an outer layer, and positive sense basically means the RNA version of that that the virus has is the same one that is translated or translatable into the proteins that the virus creates, and it infects humans and mammals. The reservoir is unknown, but there is speculation that the reservoir is a bat, and somehow the bat managed to infect an intermediate host, which is the pangolin. So if our colleague, Dr. Goldman is on, this is her favorite animal. And so they think through a wet market in Wuhan, humans came in contact either with the bats or the pangolins, and that's where transmission happened. SARS-CoV transmission is through respiratory droplets produced when an infected person coughs, sneezes, or talks. Other possible modes include handshaking, aerosols, fecal-oral, and the WHO recently has been more definitive about the possibility of aerosol transmission. Initially, the reported symptoms were fever or chills, cough or shortness of breath or difficulty breathing. Symptoms that were identified over time include fatigue, muscle or body aches, headache, a new loss of taste or smell, a sore throat, congestion or a runny nose, nausea or vomiting, and diarrhea. And these are just data from a publication from the CDC at the end of June, which looked at the reported symptoms among lab-confirmed cases. So 28% had known symptom status, so they had data on 28% of the lab-confirmed cases. The most frequently reported symptom was cough, followed by fever, then myalgia, which is body pain basically, headache, shortness of breath, sore throat, diarrhea, nausea, vomiting, loss of smell or taste, abdominal pain, and runny nose. I'm going to skip this for now. I want to talk a little bit about COVID testing because it's something that's in the news or not a lot, and there are kind of 2 tests that people are talking about. One is the RNA test, and one is the antibody test. So the RNA test, you will be able to detect RNA earlier in the course of the infection, and that goes down over time. At the same time, at least for IgG, you will not be able to detect antibodies at the very beginning of infection, but the longer you have the infection, the more likely you are able to test antibodies. But there is a bunch of reports that are suggesting that the antibodies wane, meaning they kind of disappear after about 3 months. But we're still looking in to see how long the antibodies last and whether or not that means that you are not immune. In fact, we are not sure if antibodies confer immunity or they protect you. So that's why even though people get tested and they test antibody positive, we still ask people to socially distance and to wear a mask because we don't know if you're immune from getting it again or at all. So the last thing I thought I would do is present some data, and Dr. Goodman is a biostatistician and she loves data too. So if you want to chime in at all, please feel free. So first I thought I would show you where to get some data. If you want to look on your own, you can go to the Hopkins COVID dashboard. These data are downloadable. So the dashboard is coronavirus.jhu.edu. You can just type in that first part and you're fine. And you can get the data at GitHub, but if you go to the Hopkins dashboard, you can click on, they have a link to get to the data. The WHO has a tracking website, which is covid.who.int. The CDC tracks it, so that's cdc.gov/COVID data tracker/number of cases. And there's also a COVID tracking project at the Atlantic, which is covidtracking.com. And they actually do tracking by race, which is something that we're particularly interested in for this class. All right, so the latest case counts, which I updated about 20 minutes before this lecture. So the CDC, their website was reporting 4.16 million cases. Hopkins was reporting 4.26 million cases. In terms of deaths, CDC was reporting almost 146,000 deaths, and Hopkins was reporting 147,000 deaths. So part of the reasons why there is a difference is that Hopkins updates their cases in real time, and the CDC, I don't think, updates them as frequently. The other piece of data I wanted to give you is the cases per 100,000 people, which is 1,240.4. So people in public health were interested in case counts, but in order to understand the burden of disease, rates are more important because they account for differences across populations. So for example, one case in Hawaii and one case in New York is not necessarily the same burden of disease because Hawaii has a smaller population than New York, right? So in Hawaii, let's say that that's 1 in a million. In New York City, one case is 1 in 8.4 million, right? So the rate would be lower in New York, even though they have the same number of cases. And that's going to be important for the rest of the week to understand that we tend to think in proportions and rates, or percents and rates, not strictly in case counts, because when we're looking at the burden of disease, we want to look at how many people in that population have relative to the number of people in another population that have it. This is the global epidemic curve for WHO. So it's color-coded by WHO region. So the Americas includes North and South America and the Caribbean. Europe is, and that's in orange, Europe is in green. Southeast Asia is in purple. The Eastern Mediterranean is in green. Africa is in blue, and the Western Pacific is in pink. And so you will see that the vast majority of cases are in the Americas, and we know that a lot of those are in the US and Brazil. I will also point out that these are reported cases. So I think Dr. Goodman is going to talk a little bit about measurement, but anytime you look at these numbers, realize that this relies on countries or states or cities reporting cases, and it's also a function of how many people are getting tested. This is the US epidemic curve. This is from last night, and this is the 7-day moving averages in red. And the number of cases, I think that's per day, is in blue. And you can see that we had one peak in April, right? And then we're having another peak in July. And if you go back to the Epi curve, when we were talking about the different types of Epi curve, this is very consistent with a person-to-person transmission, where each curve is taller than the previous one. And so, but this is for the entire US. Now, that is going to hide variation. This is the New York City epidemic curve, right? So our curve looks different than the overall curve because we had a peak in April, and now that has come down precipitously. This is a choropleth map of COVID cases globally. So the darker the blue, the more cases. These are case counts, not rates. But you can see that the US, Brazil, China, India, South Africa, and a few other countries all have over 300,000 confirmed cases. When you look at the, and globally, as of yesterday afternoon, there were over 15.8 million cases and 640,000 deaths. That's higher today. This is a choropleth map of COVID cases in the US. So you can see where there are hotspots by state, and this is consistent with the reporting. You hear them talking a lot about California, Texas, Illinois, Florida, even New York. These are total cases. And if you look by county, you can see that the state maps obscure quite a bit of variability across states. So not all of Texas is in the red. The darker the red, the more cases. And this is a map of New York. And so you can see that there are a few hotspots in Queens. I think that dark spot towards the bottom is Brooklyn, and obviously in the Bronx and parts of Staten Island. The darker the purple, the more cases. And that's a case rate, actually. And so when we think about disparities, there seems to be, well, there is substantial disparities in hospitalizations and deaths. And we can document outrageous racial and ethnic COVID disparities. We suspect there are disparities by socioeconomic status. So SES are measures like poverty, income, educational attainment, or employment, but such data are not really reported on a regular basis. So where there's more data about racial and ethnic disparities in COVID-19 hospitalizations and death than there is by socioeconomic status. This is looking by age. So we know that older people are more likely to die. So this is COVID deaths by age. So older people are more likely to die from COVID, or sorry, more older people have died from COVID than other groups, and it kind of goes, the number of deaths go up as age goes up. When you look at age-adjusted hospitalizations by race and ethnicity, non-Hispanic American Indians or Alaskan Natives, non-Hispanic Blacks, and Hispanics or Latinos have substantially higher hospitalization rates than Asians or Pacific Islanders and non-Hispanic whites. Although keep in mind, Asians and Pacific Islanders, there is variation there. And there was recently an article in the LA Times talking about COVID disparities among Pacific Islanders in California. These are looking at COVID deaths by race and ethnicity. So the purple bar is the percent of the US population for that group. The yellow bar is the percent of COVID deaths in that group. And then the green bar is the death rates per 1,000. So, for example, white people make up 60.2% of the US population. They account for 52.5% of COVID deaths, and 28 white people per 100,000 die from COVID. So non-Hispanic Blacks make up 12.3% of the US population. They account for 22.6% of COVID deaths, but their mortality rate for COVID is 70 per 100,000, right? So that's more than 2 times the rate of non-Hispanic whites. We also see that non-Hispanic American Indians or Alaskan Natives have elevated mortality as compared to whites, as do Hispanics or Latinos. There's a slight difference among Asians. We don't see it for Native Hawaiians or Pacific Islanders across the US. And when you look at more than one race, the death rates are lower as well. But clearly there's a mortality disparity for non-Hispanic Blacks, for non-Hispanic American Indians or Alaskan Natives, and for Hispanics or Latinos. We also know that there are underlying health conditions that place people at risk. So when we look at lab confirmed cases, any cardiovascular disease, about 32.2% of lab confirmed cases have any cardiovascular disease, about 30% have diabetes, about 17.5% have chronic lung disease, 7.6% have renal disease or kidney problems, about 5% are immunocompromised or have neurologic neurodevelopmental disorders, and about 1.4% have liver disease. We don't have poverty data, but I can show you a map of the New York City COVID death rate and the percent of people living in poverty in almost similar but not quite neighborhoods. And so this is what we would call an ecologic analysis or ecologic comparison. So this is not looking at individuals, but it's looking at communities. So we see that poverty tends to be clustered in the Bronx, which is this red area up here. I don't know if you can see my arrow. There seems to be a little overlap with elevated COVID death rates, but it doesn't seem to map on precisely. But again, this is based on community level poverty, not individual level poverty. And those data are not being reported out like that. Okay, so that's all I have. And I want to turn it over to Dr. Goodman because she is going to talk a little bit about some other aspects of COVID.
Okay, you have a bunch of questions in the Q&A. I don't know if you want to answer some now or respond to
how about while you're talking, I will respond via text.
Awesome. Okay, so I'm going to talk to you guys about measurement, missing data, and calculated rates for COVID-19. So I want to talk to you a little bit about what Dr. Ompad talked about, some of these definitions. So confirmed COVID cases and deaths are counts of individuals who coronavirus infections were confirmed by a laboratory test. Probable cases and deaths are count individuals who did not have a confirmed test, but were evaluated using criteria developed by national and local governments. So this is a key point to look at because if local governments are making the criteria, that means there's a potential that different governments are making different criteria. Some governments are reporting only confirmed cases, while others are reporting both confirmed and probable numbers. There's also another set of governments that are reporting the two types of numbers combined without providing a way to separate the confirmed from the probable cases.
They see your presenter mode, just so you know.
Oh, I'm sorry. Two screens, one computer. There you go, right? So I'm going to talk to you a little bit about how the New York Times has classified data, because I'm going to show you a bunch of charts from the New York Times. So the New York Times is using the total number of confirmed and probable counts when they are available, individually or combined. Otherwise, they're using just confirmed counts. It's also important to note that governments often revise the data or report a large increase in cases on a single day without historical revisions, which can cause an irregular pattern in the daily reported figures. The Times has said they were excluding these anomalies from 7-day averages, but they show you some of them, and I'll show you a few of them in the charts I'm going to show you. I also want to talk about statistical mechanisms of missingness, because I want to talk about the types of missingness that we are seeing. So missing at random means that the propensity for data to be missing is not related to the missing data, but it is related to some data that is observed. So there's something that we know about the person that can tell us about why their data is missing. Missing completely at random means there's no relationship between whether a data point is missing and any of the values in the data set missing or observed. So it is just what it sounds like, missing completely at random. Where missing at random is a little bit misleading because it's not really at random. We know a little bit based on our observed data what's going on. And then there's missing not at random. There's a relationship between the propensity of the value to be missing and its values. This is the case when people with the lowest education levels are missing on a variable like education, or the sickest people are most likely to drop out of a study. And so to know that your data is missing not at random means that you really need to account for missingness when you think about presenting rates. So in statistics, we sort of classify them into two groups, ignorable and non-ignorable. And those titles aren't really appropriate because just because we say it's not ignorable doesn't really mean that you can ignore it. But missing not at random is non-ignorable because the missing data mechanism itself has to be modeled as you deal with the missing data. You have to include some model for why the data is missing and what the likely values are. Whereas missing completely at random and missing at random are both considered ignorable because we don't have to include any information about the missing data itself when we're dealing with the missing data. It doesn't mean that you shouldn't, but you don't have to. So there was a data scientist who worked at the Florida Department of Health who actually was fired during the COVID pandemic, and then wrote an op-ed piece in USA Today about that whole experience. And I'm not going to get political, but there's one thing that she said in her op-ed that I think is really eye-opening, because I think for the most part, people understand that all data is flawed, but we at least thought that relative day to day you could compare. And one of the things she said that made me sort of rethink that assumption was she said that taking the number of people hospitalized today versus the number reported yesterday doesn't tell you how many more people were hospitalized in the past day. It tells you how many reports of hospitalizations the state received, which could include hospitals from back in March. The same is true for death data. So all this goes to show you that we're collecting all this data in different places. It could mean different things. The definitions could be different. And even in the same place over time, data may not be comparable. So this is a map from NBC News that shows new cases per day. I think the important thing that I sort of want to highlight here is you hear everyone say we're in the first wave, but when people look at this chart, they think, well, it kind of looks like we're in wave 2, right? This new peak is going up in a second wave. But really what's happening, as Dr. Ompad explained, is that each state sort of has a different epidemic curve. And so this is the cases for the Northeast, where we had really high levels of COVID early on, and are now sort of on the downside of our first wave. And these are the new resurgence of places like Florida, Arizona, Texas, and California that are now starting to see their initial spike. So during this part, they were really low, and this is their up curve. And so while the US as a whole looks like it's gonna have 2 humps, you have to remember that this is sort of one group of states, and this is another group of states going through their first time through the pandemic. You'll see that for New York State, this is our COVID state testing data. And as a statistician, I always hate graphs that have two axes, but I'm gonna show you sort of what's going on because they're trying to present a lot of information on one chart. So the orange, the light and the dark orange are daily total tests, and the darker orange are daily positive tests, and that's on this first scale. So that's number of tests, right? It's not even a rate, it's just number of tests. And then this blue line is the percent positive rate. That's on this scale, right? So it goes 0 to 50%, right? So we were up near 50% positive in New York State, sort of at the beginning of April. The interesting thing is, yes, the positivity rate is going down, but the number of tests are also going up. So you just have to be careful about how you read some of this data, because the rate is going to go down if I just have a lot more tests, particularly if I have a lot more tests of people who are not positive. And likely that came from us changing the criteria of who could be tested, right? So in the beginning, only people with symptoms could be tested. And so you were getting a lot more positives. And then once you open up testing to sort of everyone, like you say, everyone who was protesting, come get a test, you're going to get a lot more negative. So a lot of this change is really a policy change, right? That's sort of what happens here. So in New York State, we can also see our daily reported deaths. This is New York Times data. This is their 7-day average. They use a 7-day average to create a smoother curve so that when there's little bumps in the curve, they don't make the curve completely unsmooth. Although you can see here that if there's still a few days where there's a peak, you're gonna see little blips and fall. So it's an average of the previous, that day and the previous 6 days. So each one on this dark red chart is an average of that day and the previous 6 days. And I had mentioned before that they talked about some anomalies in the data, which they took out of this smooth curve. But I actually like that in the death data, they actually show you some days that had really, really high data. And so the interesting thing here for me is that it makes sense that we would have some blips here. If you watched our governor, he often talked about they didn't get good data on the weekend, and then maybe on a Monday, there were lots of new cases. What's interesting to me here, though, is why there would be a jump in July when we had a lot fewer deaths, to have a lot new deaths. And this potentially could be part of that reclassification issue of deaths being reclassified, but then they're not taking out of the historical count, they're just sort of re-added. So moving a case from probable to confirmed death. I also want to show you some interesting data about the percent change in reopening, but also about the presentation of this data. So clearly whoever created this graph wanted to highlight Florida, which does have a big increase. But there's also this other gray line back here that I'm trying to figure out what state this is that has a really high increase that's not highlighted, along with Arizona, South Carolina, Texas, and Georgia. And so when you're looking at figures the way they're presented, know that the person creating a figure had a message they wanted to tell. But that doesn't mean that that's the only message that you can glean from that figure. And I'm really interested in trying to figure out, one, why this state isn't highlighted more, and what state that is. And I don't have to go pull data to look at it. So one of the places that Dr. Ompad sent you guys was the Hopkins dashboard. And I just pulled data for 2 states from the Hopkins dashboard. And I pulled New York and Florida, mainly because we are in different places in our epidemiologic curve. And while I thought this dashboard was useful, there were some things that I thought about it that were problematic. If you just look at it on the surface, it looks like the 2 states are quite similar. But New York has plus 468 new cases. This data was pulled on Monday, July 20th. And Florida had over 12,000. But these charts don't really show you how different that is. And similarly, the daily test and the percent positive rate. So New York has a 1.2 positive rate, and so the line is in blue. And Florida has an 18.7 positive rate, which is above their threshold. And so it has a line in red. But I think someone looking at this dashboard offhand doesn't necessarily pick up how different these 2 states are. In our simplicity, or in their simplicity of trying to present the same data, when you look at it side to side, you can't always see what's going on. They do give you a great explanation, and I think the little arrows are great in terms of trending up, trending down, no change. And then when they have these dotted lines, it means below the threshold or above the threshold. So COVID-19 deaths in New York City, like I talked about, some places are showing confirmed and probable cases separately. And I think what's most challenging about this is that the probable deaths are really high in relation to the confirmed deaths. So there's a lot of cases that we have in the probable category in relation to how many we have actually confirmed, and a lot of that has to do with testing, the availability of tests, and then who was eligible to get tests. I think the other interesting thing is that even within hospitals, they have a high probability of probable deaths. I was expecting it more to be in residences because most of the mortality data comes from hospitals. But even in the place where we're getting most of our data, the proportion of probable deaths is high. And then when we look at this by race, ethnicity, it really shows you that these are true irrespective of race, ethnicity, that there's still a high number of probable deaths across all racial ethnic groups. I talked about this, but they did revise the definitions a little bit. Dr. Ompad showed you those, so I'm not going to go through them. Also wanted to show you data by borough of New York City and age. Shows you that in New York City, older adults have the highest rates irrespective of the borough of residence. But we also have a little bit of data on children, looking at childhood mortality data by race, ethnicity. We see that the rate for Blacks and Hispanics are higher than those of Asian and Pacific Islanders and whites, and particularly Blacks have a really higher increased rate of childhood mortality from COVID. These charts also show coronavirus cases by age, across race. You know, it's great when people try to show two types of data in one, but I think the challenge is that most people miss some of this. This reference bar for all and white are at the 50, but for Black and Latino, they are at the 100. And even though they're further apart, I think most people miss that distinction, is that this is a much higher threshold that these are crossing. We see that with age, it increases by race. And then as we sort of know, Blacks have and Latinos are disproportionately number of cases of COVID-19. Dr. Ompad already showed you the map of where cases are in New York City. And I think the important message that you should take from that is that the outbreak is worse in areas with lower incomes and in places where there's more dense housing, so where people are living closer together. And then my last slide, I just want to take a clip that came from the New York Times. I probably have made you feel like all the data is wrong, and it probably is, but I think some of it is definitely useful in terms of trying to figure out what's going on. But it's true that as stark as the disparities appear to be, it's possible that in reality they're much worse. The city has been counting probable deaths from the virus, but really has not released that data by zip code. And really it suggests that those who are most vulnerable had the least access to testing, making the situation even more challenging. So with that, we will take questions.
So I've been answering some of the questions in the chat, and I will continue to do that. And maybe I'm in the middle. Maybe since yours was at the end, you'll skip to the end and we can tag team some of the questions. I don't think we're going to be able to get to all of the questions, but we will try to answer as many as we can. I already start to see in the chat conversations about the health disparities and why those might be happening. And I saw that somebody has already talked about redlining and it being about racism and things like that. So I'm glad that you're thinking about that, because I think that is going to be unpacked a little bit Tuesday through Friday. So
yeah, I don't want to give away all the other talks, but we're going to address, the other speakers are really going to address some of the social factors which contribute to disparities. So you'll have a lot more time to go in depth and discuss some of those issues.
Okay, so I'm trying to find questions that I can answer very succinctly.
One is why is the United States having such a bad COVID response? I think lots of people could talk about different ways, but I think the countries that we saw do really well had a national response to COVID in their country, and we did not. We took more of a localized approach. And the issue with the localized approach is that COVID doesn't respect the New York, New Jersey state boundaries. It's not going to respect the boundaries of which our political power, like our governor can only do stuff in New York, the New Jersey governor can only do stuff in New Jersey. And so I think one of the things that we should have had is sort of a national strategy to address COVID.
So there's a question about the CDC no longer receiving COVID data and whether or not that affects the disease count. My understanding is that's still up in the air, the extent to which the CDC is or is not going to receive data. And the extent to which it will affect the case count remains to be seen. I just hope that whatever organization is getting the COVID data has an epidemiologist and a biostatistician to analyze the data. So that one I think I answered live. There's been a lot of questions about the tests. So there's an RNA test and there's an antibody test. And for the most part, the RNA test is going to tell you if you actively have virus. However, there have been some people, and there was a report that came out of South Korea about this, that tested positive for the virus months after they had had COVID symptoms, and they thought that they had been reinfected, but actually they were just detecting COVID virus particles, not the actual virus itself. And so that can potentially happen. The antibody test is a test of your body's response to COVID. So it'll tell you if you've been exposed to COVID. So IgM is going to tell you if you're relatively early in the infection, because IgM, remember, is the big antibody that usually that response is mounted first. And then IgG is the more specific, longer term immune response, at least for antibodies. Now, what I didn't talk about is that there are other molecules or cells in your body that make up your immune response, and that includes T cells and T cell immunity. Also, there's some chemicals called cytokines that also play a role in immunity. The main focus has been on antibody testing because that will tell us if you've been exposed. But when it comes to determining whether or not there's immunity, scientists are looking at both antibody-related immunity, but also T-cell immunity. Oh my gosh, there's 92 questions. Okay.
I'm scrolling too, there's so many.
This is great that you guys have such great questions.
There's a question about if you have COVID, can you get infected again?
We don't know. So I know that people find it very frustrating when scientists, researchers, or quite frankly, anybody says we don't know, but I would much rather have someone say we don't know than give me an answer that's not true. And quite frankly, we do not know if you can get it again. There are anecdotal reports of people getting COVID again, but we're not sure if that's a reinfection or if they actually get a new infection or it's a reactivation of their previous infection. So we're still trying to figure that out.
Someone asked, why didn't the WHO declare the pandemic until March? Is there a technical reason for that?
There's probably a partial technical reason, but I also think to some extent it was probably political. Remember that the WHO is a governing body that's part of the United Nations, and the WHO brings together countries and basically tries to get countries to do things, right? So it's they don't have power in terms of being able to say, US, you have to use this test. Brazil, you need to do this. China, you need to do this. You know, Japan, you need to do this. They have no control. What they can do is provide guidelines and suggestions and employ diplomacy to try to get countries to act in specific ways. So it was probably partially an issue related to, you know, what the technical requirements are to declare a pandemic, but I even think among people in the know in public health, there was some concern that they waited so long to declare a pandemic.
Someone asked, why are Asians less infected? We don't have empirical evidence, but there is some data to suggest that they were wearing masks much earlier in the epidemic than most other American groups. And they also had some particularly that are connected to their, wherever they're from, like China or India. People had some connections to figure out what was going on in other countries. And so it seems that some communities adopted masks a little bit earlier than the mask mandate came out. So people have to test empirically if that is the reason why Asians are less infected. That's one of the hypotheses that people are considering.
Okay, what else have we got here?
So someone asked about the 7-day line. People use a 7-day average because it makes the curve smoother instead of having a bunch of jagged marks like a 3-year-old drew the graph. You want it to be a little bit smoother, and so they take a 7-day rolling average because you don't expect the 7-day average to change that much day to day unless there's really big spikes.
Somebody asked about the graduate degree that we were talking about in the beginning. So I will say at NYU in particular, we have several graduate degrees in public health. We have a master's in public health, or an MPH, and you can do an MPH in biostatistics, epidemiology, social and behavioral sciences, what am I forgetting?
Nutrition.
Yeah,
global health,
global health,
public health policy and management.
There you go. But we also have a couple of MS, Masters in Science degrees. We have an MS in biostatistics and a new MS in epidemiology. And we also have an MS in bioethics. So bioethics, for those of you who don't know, are ethics related to biology, but for us in particular, it's related to public health, to research, to experimentation with people or with communities, and it also relates to the ethics of providing care. And so we have a great bioethics department. If you take Epi or biostats, you could have Dr. Goodman or myself as a professor.
And for all of our concentrations, the GRE is waived this year because of COVID. So because people can't take the GRE, we've waived it for all applicants. And we are still accepting applications for this fall if students are interested in getting into public health right away.
Somebody is asking, we can't eradicate the virus totally at any stage. And I will say we don't know. And one of the reasons why we don't know is because we don't know if infection creates long-lasting immunity. And we don't know if a vaccine would provide long-lasting immunity. So if this ends up being something like the seasonal flu, where you have to have a vaccine periodically, the likelihood that we can eliminate or eradicate it is low. However, if we do find out that we get long-lasting immunity once we have an infection, then the likelihood that we could eliminate or eradicate it is possible. But there's only one disease that we have ever eradicated ever in the world, and that is smallpox. And that was because we had a very effective vaccine. And that most people got vaccinated. We had almost eliminated measles, but then people stopped vaccinating. There's an anti-vax movement. And so now we've had outbreaks of measles. There is one other disease that is almost eradicated, which is guinea worm. So that's almost eradicated. And then polio, somebody is asking about. Yes, we were well on our way to polio eradication. At some point, it was only in 4 countries, but COVID-19 has actually had an impact on vaccination rates. So there's concern about resurgence in polio. And basically wars and other issues have undermined some of the polio eradication efforts.
Unrelated, someone asked if they can still submit their GRE, even though it's waived, and absolutely you can submit your GRE score. You should submit display yourself as the best possible candidate.
And I'm just going to say, come to the dark side of epidemiology or biostatistics.
We could agree to disagree.
We could agree to disagree. But, you know, biostatistics and epidemiology, we get along like peas and carrots.
We do. We're cousins.
We are.
I think we should end here. We'll save the chat and bring up any questions for next time. Thank you guys so much for joining us.
Thank you. And hopefully we'll see you all tomorrow. And we'll have some answers for you about some of the other issues that were brought up.